This session is going to be moderated by Noemi Mendez of the College of Health and Human Services. She is a Department of Health Science, and she's also a Black Health Equity intern. And she's finishing up her first year in our MPH, or Masters in Public Health program. So thank you, Noemi. We'll transition to you.
All right, thank you so much, Dr. Johnson. Very excited to be here with you and with all of the panelists. This was a great segue to this next panel, so thank you so much. So with that, we'll begin with some introductions of our panelists. So first, we will start with Ms. Phaedra Allen. So Phaedra holds a Bachelor of Arts degree in Psychology and African American Studies from California State University, Fullerton, also a Master of Social Work degree from the University of Southern California, and a certificate in Diversity and Inclusion from Cornell University. She is currently employed with Cal State Long Beach, where she serves in administration as a program coordinator and a lecturer with the School of Social Work. A member of the Executive Board of Directors for the African American Cultural Center of Long Beach and chair of the Programs Committee. Phaedra has been an active community partner in the Black Health Equity Collaborative. So welcome, Ms. Allen, and thank you for joining us.
Thank you for having me. I'm excited.
Awesome. So next we will have Ms. Alicia Culture. So Mrs. Alicia Culture earned a master's degree of social work centered in critical race theory from California State University, Dominguez Hills, and a master's degree of public health from the University of California, Los Angeles. She has over 15 years of experience in advocating for Black, Brown, and Indigenous people in the healthcare space. She is the CEO and co-owner of Advantage Healthcare Now, and is committed to advocacy for vulnerable groups within the healthcare space by providing health education. Most recently, Advantage Health Now, LLC, was awarded a grant from the City of Long Beach to provide health education centered around the Black community and COVID-19. So welcome, Mrs. Culture, and thank you for joining us. All right. So next we have with us Ms. Veronica Clanton-Higgins. So Veronica Clanton-Higgins earned her master's in social work from the University of Southern California and is currently pursuing her doctorate in social work. She is a therapist, author, adjunct professor, and TEDx Compton Boulevard founder. A native of Compton, California, she is known for her community advocacy, including addressing the disparities in mental health care for Black and Brown communities. And through her consulting from BCH Prosperity Consulting, she ensures that people are provided the tools necessary to navigate the complexities of life and break intergenerational cycles of damaging behavior. So welcome, Ms. Clanton-Higgins, and thank you for joining us.
My pleasure. Thank you for having me.
Thank you. Next, we have with us Dr. Kineka Hull. Dr. Hull is a reproductive, maternal, and child health researcher who focuses on reducing unintended pregnancies and improving birth outcomes among Black women. She is also the founder and CEO of Kinetics Research Solutions, LLC, which provides evaluation services, training on health equity and implicit bias, and certifies sexual and reproductive health educators on evidence-based curricula. Welcome, Dr. Hull, and thank you for joining us.
Thank you for having me.
Thank you. So next we have with us Empress Angelique Jackson. Empress Angelique Jackson is a certified transformational life coach, alchemist, speaker, holistic therapy, and quantum energy practitioner. She has led women to not only heal, but to empower them to live their life powerfully, abundantly, and authentic. Empress Angelique's professional career spans over 20 years within the holistic therapy, beauty industry, consulting, and higher education. She has worked with numerous organizations such as Battered Women and Children's Shelters, American Cancer Association, American Foundation on Suicide Prevention, Black Mental Health, and is currently a member of Be Well Collaborative, a Black mental health organization dedicated to restoration, wellness, health, and healing. Welcome, Empress Jackson, and thank you for joining us.
Thank you for having me.
All right, and next, and certainly not the least, we have Miss April Parker. April Parker is a successful entrepreneur turned community organizer. She is known for creating such well-known brands as Eden Body Works and Color Band Shoes. In 2018, she founded the April Parker Foundation to empower, support, and strengthen children, families, and community through culturally engaging services that promote stability, security, and well-being. Welcome, Mrs. Parker, and thank you for joining us this evening.
Thank you for having me.
Awesome. All right. Well, I'm very excited to be here with you all again. And with that, we'll start our panel discussion. All right. And so I will ask questions, and each panelist is free to answer any question as we go through all the questions. And for the audience as well, you can please enter all your questions on the chat. All right. So the first question is, what does health equity mean to you?
For me, health equity means that no matter where I live, the color of my skin, what my income is, that I have equitable access to quality of life, to health, and that is supported by my community, by the government, and all the other governmental agencies.
I agree. I think that that support should ensure that everyone, regardless of creed, walk of life, color, is able to have a healthy and a happy and sustainable way of life. I think that a lot of times we use the catchphrases of equity and things of that nature and don't look at the long-term impact. I know for me as a researcher, you come up with this great project, you go in, you do a fantastic job, and then as soon as you leave, you don't leave that community in a sustainable position. So I think that we have to really look at health equity as being sustainable and making sure that that happiness and that well-being is long lasting.
And I would
agree.
just add to that. Oh, sorry. I just wanted to add to that too, because just also clarifying what equity is. Equity is not equal. And I think sometimes we get the two confused, right? What equity is a distribution to meet the need, right? So when we're talking about equality, that means everybody gets the same number of resources, right? But when we're talking about equity, we're talking about communities getting what they specifically need. And if there's certain communities that have a different need, right? It's meeting that need so that everyone has a fair shot, right? To get over whatever that hurdle is. So just wanted to throw that in there.
Yes, most definitely. And to just add to that, I believe that part of health equity is having the ability to be able to have fair, diverse, and just opportunities that deal with mind, body, and spirit. So that diversity and that understanding and that inclusion and that opportunity to be able to access that which that community needs or that individual needs on all spectrums, from your mind, your body, and your spirit. So that means access to homeopathic and naturopathic medicine. It means being able to have access to insurance that is more diverse, that gives more opportunity for access to the needs that they need. So herbalism, and just including all of those things, because it's all very much vital within our community.
And just to add to that, we also want safe access. So when you think about Black women and maternal mortality and our babies that are dying at birth, we want safe access. So we want it to be equitable and we want it to be safe. So that's what health equity, it's far reaching. And, but then I feel that one of the number one things is we want safe access. And I like to give examples. So I was talking with a OBGYN, and she was working at a local hospital, and I won't say the hospital, but it's a magnet hospital. And she has patients that she takes Medicaid, which a lot of physicians do not take Medicaid. And the hospital did not want her to use certain equipment on her patients that were C-section patients. And this treatment or this machine reduces the risk of them having issues with their incision. And the hospital said because the Medicaid reimbursement was so low, they didn't want her using that machinery. And that was specifically for her Black and brown patients. Those are the majority of her patients that have Medicaid. And so we want equity and we want safety as well, even if we have access.
And I would like to piggyback off what my sister Queens had just stated. When we're looking at access and safe choices, as well as when it comes to mental health, we want to look at a framework that decolonizes mental health therapy to make it more culturally relevant and accessible to those who really need it. Because when we're looking at equity, we're looking at what is right for that population. And when we're looking at mental health, a lot of times it's built on a framework of white cisgender males. And so when we're looking at building access, we want safety and we want it to be relevant. So we have to decolonize mental health therapy in order for it to be reflective of the populations that we serve.
Thank you so much. So many great points, and even, especially decolonization of health. So very great points. Thank you so much. Let's move on to the next one. So how has your work contributed to health equity?
Well, for me, we deal with a lot of youth and families, and our work is really in advocacy. And actually, I mentioned earlier, there are so many resources and services to help bridge the gap for people of color that we just are unaware of, that we literally have to ask for, that no one's offering. And so a lot of our work that we think has been impactful has been in making sure that people get access to the resources that they are entitled to. And even when there's a no, we continue to advocate, we appeal, and we do what it takes to get to yes, to meet the needs of the community.
I would like to just go again. I'm all about collaboration and community and empowering. Ms. Phaedra Allen, I don't know if you remember me, but I ran the intern program over at a local nonprofit. And so that's when we pour back into clinicians or social workers that look like ourselves. And so that's how we also promote equity through education, through empowerment, through sharing of resources, and through collaboration, because we are collectivism. We are not ego-centered. We are about what serves the greater good of the collective so we can move it forward. And the work that I do with students, with clients in the community is always reflective of what is the greater goal and how can we move ourselves together forward as a collective, and that's through educating, empowering, and engaging with the community and collaboration as well.
Exactly. And to your point about education, informing individuals of their rights. So when people know their rights, they're empowered to speak without a shake in their voice. And even if they have a shake in their voice, they're still confident in what they're saying, and that what they're saying is going to benefit them and what they're saying is right. Versus doing the work for someone, you educate them on their rights so that when you're no longer there, then the individual can then move forward and work on their own, because Alicia is not going to always be there to advocate for them. But if they're there and if they know the information, we empower them with their rights as a citizen, because we have to remind Black and brown people, you are a citizen, you have those rights within America. And so once we educate them with that, they're able to then move forward with confidence.
So my work impacts health equity on a couple of different levels. So on the individual level, I work with young women from 6th grade to age 29, and I talk to them about their reproductive and sexual health. So we know that the reproductive freedoms that women of color have experienced have been traumatic from slavery until now. And so we have a lot of conversations about the ownership that you have over your body and the options that you have when it comes to contraceptive methods, when it comes to consent, when it comes to menstruation products. And so as a college professor, I see the majority of my students having some type of issue with affording menstrual products. We know that 1 in 6 African-American women between the ages of 20 and 24 may experience an unintended pregnancy. So that has all type of mental health implications, educational attainment implications. And so I'm working with them on how to have a mix between an Aisha Curry and a Cardi B. And so how to exert that in a way that it's not with the don't be fast and the typical other over sexualizations that we see. I work on it from a population level. I work with local school districts to supplement their sexual health education in the classroom and do it in a way that's culturally tailored. So we're talking a lot about what that particular district needs. So having them come up with something, because we have all of these formal sexual health educations, but if you're not talking about the lived experiences, I like what Deanna said earlier, that my grandmother's mother's mother told us about sex and told us about allowing the government to implant things into your body. When you're talking about how wonderful these things are, I'm not receptive. And so talking about a lot of the cultural and vicarious lived experiences that we talk about in our sister circles that may prevent us from picking a contraceptive method that might actually be best fit for us, that we're just not open to because of all of the negative things that we have heard. And so I look at it also from a systemic issue, because I actually go to the school boards and say, okay, so the students are having sex whether you or the parents want to acknowledge it or not. And so coming up with a way that is palatable for the individuals who are administrators. And then I also, as an educator, train other sexuality, reproductive health specialists of color. I know that just from speaking with students and myself, I'm more receptive to a provider who looks like me, who speaks the same language as I do, who knows how to get that vernacular down pat and say, look, okay, so this is what you need to do. And so just being able to do that, I'm able to hit it on different levels.
And as for me, some of how I'm able to, and the work that I do to impact health equity is through various different ways. So from a individual level, I help individuals be able to, I do what's called holistic grief and trauma release. So I help them to be able to release that trauma, release the grief, really be able to take that identity of a victim or of what society tries to input upon them and shift it away so that they can claim their power back, so that they can stand in their grace and be able to be more aligned with the empowerment of who they are and moving forward, that they can be able to heal through the trauma, they can heal through whatever happens. So we do that in a way, in a holistic way, from wound healing. We have safe, what I call goddess circles or sister circles, where it's a safe, inclusive environment where they can be open and be able to share and be able to express what they may be going through. So working with women who may be in domestic violence situations, working with women who may have been sexually assaulted or abused in some kind of way, working through childhood traumas, working through a lot of those things in a holistic way to release that away from them so that they can really be able to feel more whole. And so the work that I do is that wholeness. So holistic is whole, mind, body, spirit. So I should actually being able to shift their mindset, shift the way that they speak to themselves, shift the way that they see themselves, to be able to see themselves in the beauty and the light that they are, to be able to move forward in knowing that anything that they desire is possible, that they are beautiful inside and out, that they are magnificent, that they are worthy of so much more than what society may put upon them. Because, so that's part of the work that I do from an individual level. From a collective community level, I love to collaborate with other organizations, like being a member of the Be Well Collaborative, where we put on webinars and events that's geared around social justice and also around mental health, holistic health, and utilizing the different modalities in that. working with Day of Healing, which is led by Shelley, who is prominent in, she's an artivist, and she's an amazing healer herself, and working with those and just collaborating within the community. So bringing resources to the community to let them know that there are many ways in which you can heal and be able to take off all of the things that you think you don't have, you know. So being able to have access to understanding what you're eating, having access to growing food, how to grow your food, having access to being able to say, what am I consuming that's helping me or maybe hurting me in physically or mentally or whatnot, so that you can really just really become more healthy. Because when you're healthy as an individual, you're also healthy as a community, and that moves us forward to being more empowered and more vibrant and more alive. So I think that's part of the things that I do on that level. On the other level would be from a corporate standpoint, where I go into corporations and I teach leaders within the company about holistic leadership. And what that is how to help your employees feel more balanced, less stressed, different techniques and modalities in which they can incorporate, like meditation and journaling and stress, reducing stress and walking away, having breaks that allows that individual, that employee, to be able to get back and center themselves, because a balanced employee is a more productive employee. A happy employee actually helps your organization vision and mission move forward. So those are just some of the ways in which I've been able to, that my work that I'm doing has been able to move it forward.
All right, thank you all. It sounds like all of you are doing a lot of work around health equity, so that's really great. It's great to hear that. So now, in the context of health equity, what does achieving Black health equity mean?
Okay, I'll break the silence. Okay.
Thank you.
So no worries. So the achieving Black health equity, and I always come from a mental health standpoint, because it's very critical that when a person walks into a room, and I think Miss Kineka stated this, to speak the vernacular, they have someone that looks like them. And so in order to achieve mental health equity, we have to make sure that people who are thinking of becoming therapists have access to scholarships, they have access to grants, they have funding, because we never, number one, we know about the wealth gap, right? And so in order, it's very expensive to go to grad school to become a therapist, because a lot of people have to quit working, you're in internship, you're in class. So if we want to reduce the disparity in mental health and achieve equity, we got to have more clinicians who look like the populations that they are serving. And I think that is so critical. And Miss Alicia, Dr. Alicia, I hope I'm not forgetting your title, but when you said you like to give examples, I literally had a student that I was working with, and I'm a Black therapist at a predominantly white institution now. They called me in to help service the needs of our BIPOC students. So one student said that, I said, what's making you nervous? You've been experiencing symptoms. They said, white women make me nervous. Mind you, I'm the only Black clinician on the staff. So imagine this student who is suffering and experiencing this, not being able to share that with another clinician, because they are the ones that's making him nervous. And so that's what we achieve mental health equity, by having more clinicians, more mental health professionals. And I do not life coaches, certified healers, anyone who is reflective of the community, so we can get rid of the stigma, increase wellness, rewire those brains, get some somatic healing going on. And that way we can make a better path for upcoming generations. Because guess what? trauma is embedded in our DNA. So if we start the healing now, the next generation has a wonderful chance. So increasing access for people who look like us to get trained to become mental health professionals.
So just to piggyback off of that, I think the last sentence you said, trauma is in our DNA. I think we go in with the best intentions when it comes to equity, but we have to realize that we are combating and navigating a long history of things and a long embedded system of things. And it's not going to happen overnight. And so the start is, like you said, practitioners that look like us. So I've noticed that someone said in the chat, a Black epidemiologist, we're rare, right? So like my heart, someone said the ancestors are rejoicing looking at the panel. You know, what we do, we are rare, right? And so I remember not seeing a Black professor until college, and that was my African American studies professor, right? And being told, you know, girls are not good in science and math, especially not a Black girl that's in science and math. And so, you know, if I didn't have a mother who was an educator and who said, you know, you're going to be good because if you're the only Black girl that's good, you'll always have a job, right? I had someone who pushed me towards that. So I think representation really matters. That's the one thing I hear from my students, you know, walking into a classroom and seeing a woman of color. It's empowering. It makes them want to follow in the path. I think that we also have to really think about implicit biases. And I know a lot of times when we talk about implicit biases, we talk about biases from individuals of a different color, but we have to be real. We have some lived experiences and some biases. Like you said, you know, if she's saying that a Caucasian practitioner makes her nervous, that's an implicit bias, which is going to make her unreceptive and not compliant to whatever that treatment path may be. So just addressing that and just being mindful that it's not going to happen overnight. But if everybody is doing their small part and taking a small win, that eventually we'll see some changes.
Yeah, and I just want to echo that too. And I love this. Let me just throw that in there. I do. And, you know, just like Veronica, I side on, you know, when I'm thinking of health, I'm thinking of mental health as well, right? And just overall well-being, as, you know, Sister Angelique had also spoke to. But, you know, I think a personal mission that I took on some years ago was that, you know, I'm committed to a mission, and where I'm at, whether it's employment or whether it's an organization, that's my current platform, right? And my mission has always been to focus on inclusion and making sure that when there are Black faces in the room, that those Black faces feel included and that they feel welcomed into those spaces. Because it's not just about the numbers or having you in the room. If you're in there and you don't feel a sense of inclusion, you know, the emotional impact of that, right? The stress that comes along with that. And then also, you know, thinking about, you know, the stress is one of those intangible factors, right, that contributes to poor health outcomes for Black folks, and particularly Black women, right? So when we're thinking about that. But just kind of going back to, you know, the fact that we need more Black therapists, right? So true. But also working with our non-Black therapists to know how to work with Black folks is extremely important. And working in the School of Social Work, I serve as a lecturer there, and working with the students, I'm very, very intentional to have these conversations with students and to normalize their discomfort and to normalize their questions, right? And we have to create spaces where people are comfortable to have dialogue. Our therapists who aren't Black or who are, you know, or who are Black, right? It's such an important job, and it's such an important role that they have when they're working with our communities. So we need to be intentional to equip them with the skill set to be able to engage, right? So share some of the history, share some of the communal history, right, that they may not have. And so just keeping that in mind as well, right? So we just need to create spaces where these conversations can be had and to be intentional about that, right?
Coming from the physical health aspect, if we go back and just from public health, if we rewind back to when the pandemic first started and the then Surgeon General Jerome stood on national TV and said that Black people are dying at a higher rate because we're more likely to have diabetes, high blood pressure, ... I mean, we can dial back as to why we're more likely to have those diagnoses. We were taken from our land and we were not fed our indigenous foods. So we can start there, okay? So if we're not gonna start there, but we're gonna talk about our poor health outcomes, that is not the reason why Black people were dying at alarming rates. Black people were dying at alarming rates because when they go to the hospital, they were sent home, or they were afraid to go to the hospital because no one there looked like them, or the physicians that may look like them may not look like them, if you know what I'm saying. So we have to really understand that with health equity, as it is related to public health, the data is sometimes skewed. There's so many different things when it comes to health equity in Black people, when it comes to health care. And if our healthcare component is not on point, we can't even get to the mental health component, because guess what? There's stigma attached to that. I'm not crazy. I'm not going to see a social worker. The social worker is going to take my kids. So then there's the narrative. I mean, I'm an MSW and I spend half my day saying I don't work for DCFS, and if I did, I'm not a baby snatcher, right? And so with that said, going back to what I put that foundation, and that to piggyback off of what Ms. Veronica was saying, we need match day in healthcare for physicians to include Black students, and that they're matched and they're not getting the leftovers that no one else wanted. We need them to gain access to these environments. We need for our HBCUs to have more funding for healthcare programs, specifically physician, nursing, such programs. There's statistics that show we have less physicians, Black physicians now than we did in Jim Crow. So what we need to do is make sure that there is inclusivity in all areas of healthcare, physical, going back to Ms. Angelique and the holistic approach, and that there is representation everywhere. And that's part of, if not the biggest problem, because anyone that knows me, they know that everybody is Black. My doctor is Black, my dentist is Black, my eye doctor is Black, the painter is Black, everybody is Black. Because not only do I believe in recycling Black dollars, I also trust Black people. And so we need to make sure that we have more representation so that equity is inclusive of financial as well as healthcare.
Well said. And, I think on that note, that a lot of the training that medical doctors and mental health professionals get needs to include culturally competent information to ensure that they are aware of the challenges that African Americans face. But for health equity to happen, I think that educating our community on those disparities is important, as well as receiving the support from our community and our governmental organizations to actually do something about it, from mental health to education to employment, for housing, food, outdoor spaces, everything. All those contributing factors. And so once the money starts moving and the community starts getting engaged and the people start getting educated, that's when we can truly start to see some of the barriers, some of the gaps to close in this space.
I agree completely with everyone was saying, specifically like really being able to shift that narrative and be more inclusive, and being able to have more representation of us in all areas of health, in all ways possible, because I've been in rooms where I've been the only one. And I know with my daughter, who was suffering through depression, one of her biggest things that she would always say, because we would go from therapist to therapist to therapist, is they don't understand. They don't get me. They don't look like me. They don't represent me. And so they didn't understand where she was coming from. So it made it very difficult for her to believe in therapy, to even want to continue moving forward with therapy because of those factors of them not understanding how to work with us and not having enough representation of us within those different fields in those different areas. So inclusion is important, education is important across the board, and being able to have the resources and having representation of us in every sphere. We do need more doctors that are like us. We do need more physicians. We need to be able to just really educate in our communities on the fact that there are multiple ways and look at it as their health and healing toolbox. What's in this toolbox? You have your mental health therapist, you have your homeopathic doctors, you have your naturopaths, you have your herbalists, you have your different physicians, your social work, where we all come together inclusively, collectively, working on a way to really shift the narrative within our communities so that we get the health care that we need, so that we get the healing that we need, so that we get the education that we need to start shifting things and narrowing the gap of health inequality, so that the equity from a financial standpoint, from a mental standpoint, from a physical standpoint, from a spiritual standpoint, from a collective standpoint, we begin to rise and be able to be a healthier community so that we're no longer getting the little leftovers or the scraps or the lower, quote unquote, information or the care from doctors and physicians that where they just want to say, okay, let's just give you surgery, or I'll just give you this medication or something along those lines, things that are not really helping us to live longer, healthier lives.
Before we change this topic, I just wanted to say, as a faculty member at an HBCU, I'm finding that it's very urgent and important to stress the need for us to stay in our communities. I'm finding that not only do we have the shortages, as everyone noted, and how we need to ensure that representation matters, it's very tempting financially to sometimes not stay in our communities. And so I feel like you have to start early, emphasizing the need that we have for ourselves and our community, and how when you're doing something that you love and enjoy, the money will come. That a lot of times the reward comes from giving back. The reward comes from your impact. And I think that that is something that has to be stressed with the practitioners of color that we are producing.
My last comment is, I put a comment, where are the Black therapists? I have children that are constantly referred to DMH organizations. And when I request a Black therapist, there is none. The only place I've ever gotten a Black therapist from is Tessie, Cleveland. So there needs to be a collective to ensure that every one of these organizations that are contracted to the Department of Mental Health have a requirement based on their population to have a certain amount of minority staff on board, because pretty much everyone in Spot 8, I can hardly ever get a Black therapist.
Well,
So,
April, a lot of therapists don't want to work for DMH because of the oppressive nature of the way that it's set up. If you work from DMH, I'm sorry, but when we're looking at promoting mental health equity, it is not an institution that you will find a lot of Black therapists. So a lot of Black therapists will work for community-based organizations who may be contracted by DMH, or a lot of them start private practice. So this is where equity comes into play. A lot of Black therapists who have private practices only can take cash paying, because what we're finding, a lot of time it's hard for them to get paneled with insurance boards, right? And so that makes it difficult for the community to assess their services. But then if you want to start a private practice and make it like affordable for the community, then you suffer. So now you got to choose between a living wage and then actually servicing the community. And so DMH is great for certain things, but when we're looking at, and I'm gonna give you my number, April, we could talk offline. So when we're looking at mental health equity, you're not going to really find it within that system, because that system is based on oppression, and it has not been decolonized. And
Right,
so
and I'm talking about those community-based organizations. I've reached out to a lot of them, and so I'm saying contracted community-based organization. We have to find a way to break down that oppression, because the children and the
absolutely.
families are suffering.
Absolutely, absolutely. That's why databases like Clinicians of Color, Therapy for Black Girls, Latinx Therapy, they have a great base of clinicians of color with sliding scale, and who also take all kinds of insurances. And that can be a start. And so I don't know if that really answers your question, April, but that could be a start. Those different databases where clinicians like myself, we would actually sign up, because it's easier for people who look like us to find us.
Thank you so much for all of these golden discussions that I think we all really need to have. So from the foundation's right to representation, all of this is such an important conversation. Thank you. We're going to move on to the next question. So what role do community partnerships play in promoting Black health equity?
We are the ground troopers. We are connected to the community. We see the people. We know where they are. We know what they need. They are safe and comfortable with us. They trust us, and they want our support. They want us to love on them because we're a part of them. And so community partnerships, working with the community working together, the organizations, nonprofit, for-profit, all of us working together. You know, yes, we want help from organizations and governmental funding, but we got to take care of each other.
She took the words right out of my mouth.
Mine too.
Right?
Right, nothing else needed.
Right there, because it is important. It's like that collaboration, because no one else is going to take care of us but us. No one else is going to look after us but us. We have to step in and ensure that we create the things that we need to be able to have the resources we need to have access to the databases, because there are a lot of people who may be on this webinar right now that are not aware of these databases. So how do we continue to educate and support and be able to put that information out there to the community so that we know that we have those resources available to us, and create our own infrastructure. Stop trying to get a seat at the table somewhere else and create our own table within our community, so that we are lifting each other up, educating each other up, and bringing the health equity within our communities up.
And that you have that trust, right? That's my favorite thing about working with community organizers and community gatekeepers. The trust. So you can tell these resources, you can give all this information, but they don't know me. I'm just the person who comes in twice a week and does whatever this fancy intervention is that I thought up, right? And got money for. And so in their mind, it's kind of like, okay, she's doing this because she wants to write a paper and because she has some money. And whenever she leaves, we're just here to fend for ourselves. So I'm really big about the sustainability. And like you said, helping the community maintain and level up. And so anytime I'm able to work with a community partner, it just makes the project better. And so I appreciate you. So April, I'm giving you a hand clap on the side.
Well, I'm gonna be a Gemini. I'm a Taurus, but I'm gonna be a Gemini and say, yes, but we still got to get that money too. So all that governmental funding, all that appropriation, all those grants, all you organizations, you know, contact me, get registered to receive that federal dollars, because those are our tax dollars and I want my reparations. So yeah.
Absolutely. And then there's also the narrative, right? Being able to speak in Ebonics. When we are communicating within our pod, we're able to speak their language. So if I'm doing a webinar, you know, for my Beverly Hills group, I'm speaking in a different tone. But when I'm speaking with my people, I'm code shifting. And so with them having that knowing that I'm a community partner and I speak their language versus someone that comes in and does not speak their language and judges the language that they speak, it's a totally different approach, totally different understanding, and totally different appreciation from the community. And you're more likely to get a positive outcome. I mean, the County of Los Angeles just gave organizations up to $500,000 that were CBOs because they understand the importance of using those organizations to get the word out about COVID-19 and the vaccine. So, and multiple organizations, not just one, multiple organizations within the community, because they understand that we can't do the work by ourselves. We need people that individuals trust.
Thank you, everyone. We are going to move into questions from the audience, and we do have one. So again, if you have another question, please put it on the chat. So we have a question in the chat that says, how does structural racism producing inequitable access to housing, healthcare, education, employment, and healthy Black communities factor into this conversation?
That's a good one.
Right.
I don't even know where to start. I mean, that is the conversation. I mean, it's so deeply, it bleeds into all parts of this. I mean, when we're talking about the way communities are purposely designed, right, to reduce access to quality foods, and we start talking about food deserts, there are certain communities, I don't know how many of you have actually taken note of this, right, or how openly we're having conversations about this, but there are certain communities you will go into and you will have to drive miles before you find access to food that you'd even feel comfortable eating, right? You run into a liquor store on every corner, right? And even the church on every corner. And I'll just throw that out there as fact. You'll run into a church and a liquor store, but there may be 1 or 2 grocery stores within a zip code, right? And these are communities that a lot of our people are densely populated in, right? And so if you don't have access to nutritious food to eat, right, or if you don't have access to appropriate health care within those communities, and then you get to think about the stress levels out of that alone, right? I can go on and on. I'm gonna pull out of this one because it's a really deep question, but it's so deeply wrapped around and intertwined with itself. And these are systems, and systems work within systems to support, the continuation of the system. And so we can't look at these issues one-dimensional, right? They work in tandem with each other. And so that's why, we have to have these conversations so that we can identify what the issues are. And I think as a community, band together and develop an approach on how we want to take on the resolution of those issues, right? And address these issues as a community.
I agree completely. We do have to go in and look at, well, where are the shifts? Where are the issues? Where are the areas of opportunity to move it forward? Because we have to remember, we're fighting against a system that's been around for a very long time, that's been implemented, that was designed to put us in these food deserts, in these pockets, into having access to lower education or access to food that isn't as nutritious. Because there's a big difference when you walk into a Food for Less compared to when you walk into a Gelson's or a Whole Foods. There's a huge difference from all of those things. And so we have to remember, even in our school system, the food that is being given within the school districts in certain areas, you have more fast food, more junk in certain areas. And then in other areas, you have access to more organic and healthier types food. So it really kind of, when you think about that, and I think about when I lived in Antelope Valley, that is a food desert out. That's just a desert. That's a whole nother world out there. They don't have a Whole Foods out there. They don't have access to a lot of healthy. They mainly have food like the Food for Less and an Albertsons or a Stater Brothers, those type of things. They have a plethora of fast food places out there. They have only a couple of schools that are out there, one college that's out there, and that's a community college. And so, and they're miles away. So they really don't have the access to health. And that's where a lot of us live. We moved out there for a better life or a better community, and yet we don't have access to a lot of the things that other communities have lived. I've been able to live. I grew up in South Central LA, and I've lived in Agoura Hills. So Agoura Hills, it was vastly different. The schools were vastly different. The community is vastly different. The access to resources for education, for health, for everything was vastly different there compared to the way that I grew up. So we have to start looking at, well, what are the things that we really need to start shifting? Where are the areas of opportunity to move us into that next phase, into that evolution of being able to have access to healthier lifestyles? And there are communities that are out there that are doing amazing things, like our community gardens. I mean, how many people know about the community gardens? There's one in Watts, there's one in Willowbrook, there's one in Compton. There's so many community gardens where you can get educated on how to grow your food and healthy living. There are, there's information out there in terms of being able to look at our, like, for education and other things. So I think that it's that question is, that's a very deep question. And it's going to take more than this panel to really delve in and dissect it. But I want to say that the first thing that we have to do is start looking at how we shift it. We do need access to that funding that's out there, and being able to educate those who are out there so that we know how to gain this access to those grants and access to government contracts and funding that everyone else is getting. And so then some of the other things is just us coming together in collaboration, the way that we are, and having these discussions and these panels on an ongoing basis, and being able to start early on with our children and teaching them about health, about really living holistically. And I mean that in the sense of not just holistic therapy, but holistically, meaning in your mind, your body, and your spirit. Being able to teach them from a young age, because then that trickles into the next generations and generations to come. They learn faster early on, as opposed to being more defensive when they're older, because they've already ingrained and formed an ideology around the way life is. And so those, I don't know, those are just some of the,
I think you chime in really quickly, because I know you want to move on, but
yeah,
just thinking about this, and I want to go back to the question, because it's really a loaded question. And it's loaded because this goes back to redlining, right? So if you think about hospitals are our largest safety nets. That's number one. Our second largest safety nets are our schools, and then everything else falls in line. So when you think about, if you take, let's say, a certain part of Long Beach, or just Long Beach in general, how many hospitals are there in Long Beach? Where are the nicer hospitals? Who has access to the nicer physician offices, right? So you look at that. How is the health equity within our communities? How far do you have to drive from North Long Beach to get to an adequate hospital within your own city to obtain services? So then there's that. What do the schools look like in those neighborhoods, right? So all this goes back to living wages, right? Because there's redlining, there's lack of food. But you know, when grocery stores come in, they come in when they see that individuals can afford the services that they are rendering. If they see that you cannot afford, they're not going to build their business there. So therefore, we need to make sure that people have living wages. That goes back to education. Oh, are we going to dial it back to make sure that everyone is healthy within that community? You see, it's cyclical. So if we cannot get living wages to then encourage facilities to want to build within our communities, Kaiser, one of the things they do, before I go back on mute, they're starting to build community hospitals, not specifically hospitals where you can go and get emergency treatment, but healthcare centers. And within those healthcare centers, they have one in Baldwin Hills, they have one in Carson. And within those community centers, the people that work there are supposed to live within a certain mile range within that facility. What happens then? Then they live there, they eat there, they spend their money within that community. So we need to implement and get government and private agencies to want to then invest within our communities, which means we need a living wage act. That policy is what changes everything. We can get all the money in the world, but what happens is you got to get policy. And then when you get policy, guess what happens? You get money. CARES Act gave us money. The new act passed by President Biden gives you money. We need a living wage policy, so then money is rendered. Once money is rendered, we will start to see more opportunities within our communities.
Thank you so much, Alicia. And thank you all. This will conclude our panel. I think you all left us with lots to think about and very motivated to take action. So I really want to tell you all, it was my honor to be with you, all 6 of you on this panel. So thank you so very much.
Thank you.
Thank you for
Again,
having us.
yeah.
This was
Again,
an
I just
honor.
want to express my deep gratitude for you all. You came and you did exactly what I asked you to do, and that was talk about Black health equity. It was hard for me not to jump in because, you know, that's my love and my focus, but you all have done the job and done it well. So I honor you and I thank you for your time here tonight and all of the knowledge that you left for us to just soak up and think about. One of the things that I just want to hone in on is equity. Equity being programs, education, outreach, access that meets the needs, the specialized, tailored needs of that particular population. So unless there's no tailored culturally needs to that specific population, we're not talking about equity. In addition, we need investment, continued investment, not one-stop shop investment, but continued investment into our community so that we can continue to do the work that we've been doing at this point. So I hope taking part of this panel, you see what investment in the community, what we can accomplish, in addition to what we need to move forward. So thank you very much. I want to also, if you follow our journey on Black Health Equity LB as we seek to continue to work towards building the Black Health Equity Collaborative. I also want to thank the town hall participants, the College of Health and Human Services. I also want to send, I don't know if she's still on, but I want to send a special thank you to my dean, Dr. Lounsbury. She has known my passion and she has really supported this work. And she has really put the action behind. She said she wanted support. This is the reason why we're able to collaborate with the City of Long Beach and the Health and Human Services. So I just want to say, you know, it's one thing to say you want to support, but to actually do it. I want to express that she's the dean that's been supporting this effort. And I thank you if you're still on the line.
Rock on, Dr. Johnson, I'm here.
Okay.